If you lose estradiol, why don't you replace the estradiol? If you lose testosterone, why don't you replace the testosterone? If you lose thyroid, then why don't you replace the thyroid? Well, because we're taught and trained to do otherwise. Why? Because of the pharmaceutical industry that sort of supports our medical academies, and we don't want to shoot ourselves in the foot. So, from here on, I don't use estrogen. I don't recommend that you use estrogen, and I don't ever use estrogen. But in my world, estrogen is Premarin. I always use estradiol. I never use estrogen, if you get my drift. So it's a play on semantics. In the WHI trial, the researchers originally reported that estrogen and progesterone increase the risk of breast cancer. There is nothing that can be further from the truth. Progesterone in every single solitary study protects against breast cancer. But it says it right there that progesterone increased the risk of cancer. That was an error. What they meant to say was a progestin. Well, they later went back and corrected that and said, okay, estrogen and progestin. But what did they originally state? They stated progesterone. That was incorrect. There's no study anywhere in the world that progesterone is harmful. In fact, it's used now in research centers, and it's probably going to be leapfrogging tamoxifen and AIs as far as breast cancer protection against recurrence. Much better than AIs and tamoxifen. But yet, you'll see these studies in the US where it uses the term progesterone as a catchphrase, but that's incorrect. So, do I use estrogen? No. Do I use estradiol? Yes. Which hormone is lost? It's estradiol. Replace it. Well, you have to assume that the hormone is the same. You've assumed incorrectly. There's no study anywhere in the world showing that estradiol is harmful. There's no study anywhere in the world showing that progesterone is harmful. Show me the study. I've been waiting for 30 years for somebody to show me the study where estradiol and progesterone are harmful. Yes, but but in the WHI trial, they looked at Premarin and Provera, medroxyprogesterone acetate. They did not look at estradiol and progesterone. Well, you have to assume it's the same. This conversation is ended. The role of DHEA in psychiatry. What the heck is that? What's DHEA? Well, it's a hormone. Where's it come from? The adrenal glands. As you get older, your DHEA level falls. There's a multitude of studies. I could spend the next 3 hours and show you all the studies on the benefits of DHEA. So cortisol and DHEA are diametrically opposed to each other. As you get older, cortisol goes up, DHEA goes down. You want to get the DHEA up, which suppresses the cortisol back down. Well, how do you do that? Well, you have to give it. And what's the effect of that? Well, there's an antidepressant effect of using DHEA. Really? You use DHEA in psychiatry? Yes. There's literature for it? Yes. I so often hear, doctor, I feel so much better. Yes, I know. I'm happy. I'm not depressed. I feel great. Thank you. Yes. Which hormone was it? Yes. No, which hormone did it? Yes. Can we start one hormone at a time? No. Why? Because they're all additive. They're all synergistic. Thyroid hormones and mood disorders. You're going to use thyroid hormone for a mood disorder like depression? Yes. Is there evidence for it? Yes. I received a letter recently from an academician who's a psychiatrist who interestingly said, Dear Neil, I'm going to start a petition because I truly believe that endocrinologists should not be treating patients with hypothyroidism. Only psychiatrists should. Because only psychiatrists know how to make patients feel better. I hope you got the sarcasm in that. Why would a psychiatrist be treating a patient with depression with thyroid? Well, because it works. Does? Yes. But they're not hypothyroid. I know. But according to the guidelines, it says you can't use thyroid if the TSH is normal. Yes, that's what the guideline says. But you're using it for off-label use. And it works tremendously. So which hormone worked? I don't know. All of them work. They're all great. And how we can make people feel and function better. Testosterone has an antidepressant effect. Estradiol has an antidepressant effect. And an improvement in cognition. DHA has an antidepressant effect. And so does thyroid. And all of these together have an antidepressant effect, which is interesting. And yet we still want to use SSRIs because That's our bread and butter. But this whole entire annals of psychiatry look at the use of hormones in treating depression. What a concept. So who should be at the forefront of treating depression with hormones? What specialty should be at the forefront of treating patients with hormones to treat the depressions? Well, you think the psychiatrist. Well, the psychiatrists don't know nothing about hormones. I guess they missed that issue. Well, yeah, it just falls between the cracks. It's beyond the scope of practice. So even though my local psychiatrists know of me and know what I do, they won't treat with hormones. They'll refer the patients to me to treat them. And they've gone through the gamut of, well, we've tried 10 SSRIs and none of them worked. Well, of course they didn't work. It's not a dopamine or serotonin issue. Let me have a crack at it. And sure enough, they go back to the psychiatrist and go, I don't need you anymore. I'm fixed. Rousier fixed me. Testosterone depression, a systemic review and meta-analysis. Journal of Psychiatric Practice. Testosterone has an antidepressant effect in depressed patients, particularly those with hypogonadism, however you define that. We'll get into that definition later on. It used to be, the definition of hypogonadism was anyone that had symptoms or signs of testosterone deficiency. Then the FDA stepped in. They didn't like millions and millions of prescriptions being written for testosterone. And since the U.S. Preventive Services Task Force is a government organization that's trying to save money, they got together with the FDA and decided that we're going to restrict the use of testosterone because we don't want all these doctors prescribing it. We don't want all these patients taking it because it's going to bankrupt Medicare. So we're going to make strict requirements. And the requirements are going to be that almost everyone will not qualify for treatment. Cool. So if we put the level so low that qualifies them for treatment, then nobody will get treated because they don't qualify. It doesn't mean you can't treat them. It just means you can't make the diagnosis and you can't bill insurance for it. And Medicare has now saved trillions of dollars by not having to pay for testosterone prescriptions. And that's the system. Brain hormones and aging. This is from Biomedicina. This is an interesting description of what it is we do and why we do what we do. With age comes a diminished capacity for cellular protein synthesis. We just don't heal as much as we should or as much as we used to. One of my pet peeves is a world full of orthopedists that pin fractured hips or put in new hips, throw the people in rehab or nursing homes, and they do absolutely nothing to help them heal. Well, that's somebody else's responsibility. It's not mine. 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 Well, whose responsibility is it? It's not mine. There's a decline in immune function. An increase in fat mass? Really? Yes. What do cardiologists do to help you decrease your fat mass, to decrease your risk of cardiovascular disease? Nothing. A loss of muscle mass and strength, and how we feel and function on a daily basis. A decrease in bone mineral density for both men and women alike. There's an age-related disability that's synonymous with weakness, impaired mobility, balance, poor endurance, yada, yada, yada. You're just getting old, Fred. You're getting old, Martha. Just deal with it. But doctor, my friend is on hormones and she feels great. Oh, you don't want to take hormones. Those are bad. If a doctor's not up on it, they're down on it. And trust me, your colleagues will not be up on this. Therefore, they are going to be down on it. Trust me. I got 25 years experience with it. But nevertheless, who wants that? Physical frailty, falls, fracture, impairment of activities of daily living, loss of independence, loss of strength, loss of muscle mass, loss of ability to heal. This all sounds so good. I can't wait to get old. Osteoarthritis, sedentary lifestyle, chronic debilitating disease, all important factors in the process of frailty and getting old. Just deal with it. Traditionally, this aging process has been considered to be physiologic and unavoidable. Just deal with it. But in recent years, an increasing number of people are not willing to accept this grim stereotype of aging as an unalterable process of decline and loss. Okay, hormones are partly responsible for this change in attitude. What do you mean hormones? Yep, but your levels are normal. You don't want to take hormones, those are bad. Prem-Pro, that's bad. Estrogen, that's bad. Testosterone, you don't want to take that. That's bad. Thyroid, you don't want to take that. You're going to get osteoporosis and atrial fib. You don't want to take that. That's bad. Bad, bad, bad. And everyone's got normal levels. But why is everyone then on hormones? There's now routine medical intervention programs. What is that? What is a routine medical intervention program? It's an HRT program. It's a program where we prescribe hormones, offering long-term replacement therapy with one or more hormones. Really? Why did you give the hormones if the lab tests were normal? Because they were not optimal. And why did you do that? In order to delay the aging process and to allow us to live for a longer period in a relatively intact state. Well, some people call that anti-aging. I don't suggest that you use the term anti-aging. It is a derogatory term that's frowned upon by most physicians. When I would walk through the hospital, some of my nurses would say, "There goes Rouzier, he said anti-aging doctor." And I say, "No, he's the preventive medicine doctor. He's not the anti-aging. He doesn't do anti-aging. He does preventive medicine." The name of my clinic is Preventive Medicine Clinic. So anyway, I offer routine medical intervention programs offering one or more hormones to allow us to feel and function better for a longer period of time. So that describes what patients want. It's not a practice that we have where doctors refer patients to us typically, unless they know me. Moving on. So what about this anti-aging stuff? This is from geriatrics. The link between obesity and diseases of aging has been confirmed in studies. Yeah, we know that. Experiments provide powerful evidence that visceral fat has a direct effect on age-related insulin resistance. Yeah, we know that. How do you get rid of the visceral fat? And how do you get the visceral fat in the first place? Well, the visceral fat accumulates as we get older because our metabolism slows, because our thyroid slows. The visceral fat accumulates because we have hyperalimentation on carbohydrates and we don't work it off because we can't exercise because we're too fatigued and too tired. And even if we did, we don't have the metabolism that we used to. And as a result, we tend to gain fat. And when we gain fat, it causes dyslipidemia. And when you get the dyslipidemia, it causes plaque to form in our blood vessels, cardiovascular disease, and death. Cool. It all starts with the visceral fat. You have to get rid of the visceral fat. What do the cardiologists do to get rid of the visceral fat? What do the endocrinologists do to get rid of the visceral fat? Well, the GLP-1 receptor agonists are sort of the drugs of the century, but they're expensive and not all insurances pay for them, but otherwise you'll lose 5 or 10 pounds on a GLP-1 receptor agonist, and I think they're great medications to use. But you still have diabetes. Last year in the webinar series on testosterone, I presented probably 20 or 30 papers on the use of testosterone curing diabetes. I didn't stutter, I said cure. Well, you can control diabetes with medications and lower the hemoglobin A1C, and that's what we're all taught and trained to do because the drug companies tell us to do that. And therefore we prescribe more and more drugs, more and more insulin, more and more this, more and more that. But you still have the diabetes and the complications of diabetes and the death from macrovascular, microvascular complications. Well, what if we just didn't have the diabetes to begin with? Well, this past webinar, this past month, I looked at optimizing thyroid to reverse the metabolic syndrome and diabetes with thyroid. T4 doesn't work, you have to use T3. Last year, I spent 3 webinars showing that testosterone cures diabetes. It doesn't control it, it cures it. You mean you don't have it? No, you don't have it. As opposed to being on 3 medicines and having your hemoglobin A1C of 6? Correct, but you're on 3 meds for diabetes. You still have the diabetes, but your hemoglobin A1C is low. That doesn't mean you don't have diabetes. It means that your surrogate marker that you're chasing is low, but you still have the disease and the cancer and the heart disease and all the related complications of diabetes, even though your hemoglobin A1C is low. But with testosterone, the hemoglobin A1C is less than 6, and you don't have diabetes. You're not on diabetes medicines. You're not on any medicines. You're cured. Yeah, but you're on testosterone. Yeah, but you don't have diabetes. You're cured. Which would you rather take? So I asked Dr. Kadambi, our resident endocrinologist, I said, all of your colleagues are prescribing the GLP-1 receptor agonists, which are great, but why don't they prescribe testosterone and just cure the diabetes? Dr. Kadambi says, because you're stupid. That's coming from an endocrinologist. I said, I shook. That's sort of bold that you say that. He says, but it's true. Look at all the data and studies to show what works. I can completely cure and get rid of diabetes, but they want to still treat the diabetes with diabetes medicines, whereas when I treat the patient, they don't have diabetes anymore. I said, but isn't that a concept that you should try to teach? Yes, but they're not teachable. Okay, again, it just sort of shows you that if a doctor's not up on it, they're down on it. And we'll look at Dr. Kadambi's 91-year-old parents that are on hormones they just came back climbing Machu Picchu at age 90. Pretty impressive. So how do you get rid of the visceral fat? The increase in visceral fat tissue in older people is associated with a decrease in levels of estradiol, testosterone, and growth hormone. The one that they left out was thyroid. But when you lose your estradiol and you lose your testosterone and you lose the growth hormone, you will lose the metabolism and you'll increase in visceral fat. Augmenting the lower levels of these and other hormones that decrease with age. What does that mean? Augment the lower level of these hormones that decrease with age. What do you mean augment? Why would you augment it? The level is normal. You don't get it. Augment means the level is normal, but you're raising the level to optimal. There's a difference. That's where we're headed. And when you augment these other hormones, guess what happens? It better controls visceral fat, thereby leading to less insulin resistance and a decreased risk of diabetes and atherosclerosis. At the Beyond Hormone Symposium in October this year, I presented all the data and studies demonstrating that you can completely reverse insulin resistance and diabetes if you use the right amount of hormones, and it can reverse plaque. I presented all the studies looking at plaque reversal that you typically don't see in the majority of the studies with statins. And unfortunately with statins, there's an increase in diabetes and in insulin resistance when you take the statin, because statins have an adverse effect, they have an apoptotic effect on beta cell function in the pancreas, which is why we see an increase in diabetes and insulin resistance for those that take statins, as opposed to eliminating the insulin resistance and diabetes by giving them testosterone, and it reduces the visceral fat. I showed several papers where statins, because of the dyslipidemic effect it has, increase visceral fat. Every single solitary study with testosterone reduces visceral fat, as well as T3. Do you know any cardiologists that focus on giving hormones to reduce visceral fat other than Dr. Kandambi and maybe Dr. Pang? No. But it's something that slips between the cracks because they don't understand it. It's something that we're not taught and trained to do. I read this brand new article that it was entitled How to Prevent Prediabetes from Eventually Evolving into Type 2 Diabetes. And it listed all the diabetes medicines. It did address diet, exercise, those are given. But it looked at all of these different medications to control the diabetes. But all of those medicines control diabetes, they don't get rid of the diabetes. And except for the GLP-1 receptor agonist, all of those medicines increase visceral fat. And they make the disease worse, and we saw that in long-term outcome studies. Published in JAMA and New England Journal of Medicine last year, all the long-term greater than 10-year studies with statins and insulin to control better the hemoglobin A1C all resulted in worse outcomes. I know it's hard for you to believe that, but that's what the long-term studies showed. Because we're not controlling the visceral fat. How do you get rid of the visceral fat? Fred, you got to lose weight. Perfect. Doc, how about you? Have you looked in the mirror, Doc? Receptor site downregulation and not hormone levels themselves probably account for the symptoms of hormone deficiency, which is another concept that you need to understand in this first hour. I talked about augmenting the lower levels of hormones that decrease with age. All right, great. But there's more to it than that. Every year at the American Academy of Endocrinology, I force myself, they have a lecture that talks about endocrine disruptive chemicals, EDCs. And the lecture elaborates on the importance of understanding EDCs and what the EDCs do to the receptor sites, because there's plenty of hormone present in the serum, but the receptor site is blocked or altered somehow so that the hormone does not have an effect on the receptor site that it otherwise would have. And all we're focusing on is hormone levels, whereas we really should be focusing on the post-receptor activation and signal transduction inside the cell, as opposed to looking at the hormone level that's floating around in the blood. Because if we focus just on that, we will miss the fact that the hormone's there, but it's not working. Well, how do you get rid of the endocrine disruptive chemicals? Well, you have to live in a bubble. Well, is there some way that we can detach that endocrine disruptive chemical from the receptor site? Not that I'm aware of. So then what do you have to do? Well, you have to stimulate more receptor sites. How do you stimulate more receptor sites? You have to augment the lower levels of hormones that decrease with age. Now you're starting to understand why we do what we do. The patients will have symptoms of a deficiency even though they do not have a deficiency based on their blood test, which is always going to be normal. But they will still have symptoms that will improve when you add more into the system because you're augmenting the lower level that decreases with age to better stimulate those receptor sites, which makes the patient feel and function better. It also helps with metabolism and cholesterol and visceral fat. And all you're doing is augmenting these lower levels with a routine medical intervention program. Now you understand why it is, why we do what we do. Raising hormone levels to higher optimal levels upregulates receptor sites because you stimulate more receptors. If you have insulin resistance, what do you have to do? Well, you have to stimulate more receptor sites. How do you do that? Well, you put more insulin into the system. But more insulin causes you to retain more fat, yeah? But you have to put more insulin in because you've got insulin resistance. Yeah, but the insulin drives the glucose into the fat cell where it's stored as fat. Yeah, well then you just give more insulin. Yeah, but then you store more fat. Well, why is there insulin resistance? That's the key. Well, insulin resistance is just a fancy term for, you're probably not aware of this, insulin resistance is really not as much insulin resistance. It's hyperinsulinemia because the insulin's not working. And when the insulin doesn't work, then the body makes more of it. And that's why you have this hyperinsulinemia, because what is normally there is not working, and therefore the body has to make more of it, which raises more insulin. The more insulin you make, then it drives the glucose into the cell where it's stored as fat, which is why you get into this vicious circle, and there's your visceral fat. How do you get rid of the visceral fat? Well, you have to address the insulin resistance. Well, how do you do that? Well, you have to improve metabolism. And you have to decrease the hyperalimentation, of course, but you have to improve the metabolism. How do you improve the metabolism? How do you improve the uptake of glucose in the muscle cell where it's metabolized, as opposed to increasing the uptake of glucose into the fat cell where it's stored as fat? Well, you got to stimulate the muscle. How do you stimulate the muscle? T3 hormones, testosterone. That's what burns the glucose, and that's why we can cure diabetes, as opposed to every drug that we give for diabetes crams the glucose into the cell, which makes the cell store as fat, which makes fatty liver and fatty pancreas, and fat in the pancreas creates beta cell apoptosis, which then stops production of insulin, which then makes you diabetic. And that's the progression. And you can back upstream and simply fix it. But not everyone understands it because, no, you don't want to do that. So, raising hormone levels to higher optimal levels upregulates receptor sites, accounting for the improvement in symptoms that we see clinically, but also improvement in well-being, which is what I've addressed and alluded to, in spite of the fact that the baseline levels were normal. I understand that. So just where's this light switch that turns the hormones on and off? Just where's the light switch that turns the insulin on and off? Well, there isn't a light switch. It's a dimmer switch. Everyone wants to know that number. I don't know what the number is. It's whatever works. But what's that number? Okay, if you want that number, 4. There's your number, 4. Did that help you? No? Well, you wanted a number. There's your number, 4. Right there, there's your number. Sink your teeth into that. It's a process. Be patient with the process. So, where's the light switch? There isn't one. It's a dimmer switch. There's no on or off phenomenon. So, I've already alluded to this. Please don't treat the lab test. Use the lab test as a guide to your therapy. We were taught that in our training years and years ago, but we just don't adhere to it because we want to be focused on that number. Give me that number. Okay, 4. Great. So when do you test for that number? Well, I don't know. Well, when does it say we should test it? Well, they don't. So you can test it right away, you can test it later on, or you test it in the middle. When are we supposed to test it? What does it say to test it? It doesn't. So you're so focused on that number, but you don't know when to test that number. Because there's no guidelines as to when to test it. When should we test it? It doesn't say. Well, don't you think they should say? Yes. Well, what do they say? They don't. They just say you should test it. Great. But when? You can test it here, it's high. You can test it here, it's low. You can test it in the middle. When does it say you should test it? It doesn't. So then what's the importance of testing it? Well, there isn't really an importance. Well, what's the importance? Looking at the outcome. We're trying to look at what dose that we give results in an improvement in symptoms or signs. Not focused on, you got to achieve a certain number, because that number is going to be different in everyone. And when do you test that number? They don't say. You can test it whenever you want to. Well, when should you? God knows. I don't know. Everyone wants to know that number and when to test it. I don't know the number and I don't know when to test it. But I do know what to look at as far as signs and symptoms that improve. Those are the numbers that you should look at if you get my drift. Do treat the patient, do treat the symptom, do treat the sign, and don't ignore the post-hormone production system. The post-hormone production system is where your thyroid gland produces T4. Great. There you go. That's the hormone production system. But that T4 has to convert into T3. That's the post-hormone production system. And then the T3 has to attach onto that receptor site. And then you have to have that signal transduction inside the cell. And then that has to turn on the mRNA. It has nothing to do with the T4 production by the thyroid gland. So it's the post-hormone production system, the receptor site activation and signal transduction that we should focus on that results in an action, as opposed to looking at that serum hormone level in the blood. Clear? Moving on. I only put this in here for you to sort of read on your own. But there are statements about the use of anti-aging medicines, anti-aging hormones, anti-aging clinics, for-profit websites, compounding pharmacies, a plethora of products, antioxidants, vitamins, all considered to reverse age. Well, that's hogwash. So years ago, the AMA came out with these papers against any medicine or clinic or anyone that touts the term anti-aging, which is again why I suggest that you don't use that. What is estrogen FDA approved for? Treating symptoms of menopause. Can you make any other claims for it? Nope. What is testosterone FDA approved for? Treating symptoms of hypogonadism and, by definition, a level of less than 300. Can you make any other claims for it? No. Should you? No. If you do, you're going to get spanked. And compounding pharmacies and other clinics and other people have made all these fantastic, fabulous claims for anti-aging. You can't do that. It's nonsense. You cannot publicly advertise a hormone for other than what its FDA approval was for. Thyroid is FDA approved for treating hypothyroidism. Yes, but it does this. You can't claim that. You can't say that you do that. It's illegal to do that. You can only claim that you use thyroid to treat hypothyroidism. Well, most patients that you treat don't have hypothyroidism. Don't claim that. Don't put it out there. Trust me on this. Anyway, that was my purpose for showing this. Some of the drug companies falsely advertise beyond their FDA approval some drugs, like Zyprexa for sleep, and they got fined $1.4 billion by the FDA because they were advertising it and the reps were touting the use of Zyprexa for an unapproved use. Can't do that. Don't do it. All right. I will let you read that on your own. Moving back into the medical literature. JCEM, or Bible of Endocrinology. Testosterone and growth hormone improve body composition and muscle mass. Well, that's what happens when you get older. You lose those hormones. Not only do you use the level of it because you're not making as much of it, but you also lose the effectiveness because you have receptor site resistance at the cell level that I alluded to. Supplemental testosterone can produce significant gains in muscle mass, muscle strength, aerobic endurance, with significant reduction in whole body fat and trunk fat. would think that the cardiovascular world would jump all over this. You would think that the endocrine world would jump all over this also. You think wrong. But look at these studies. Look at all the data. There's thousands of studies that show the same thing. You would think that they would jump all over it. They do not. In fact, they're absolutely against it. The doctor's not up on it. They're down on it. Why are they down on it? I can't explain it. It's beyond their scope of practice. It's beyond their scope of comprehension. They just don't like it. Yes, but all the studies show it works wonders. I know. But why do we ignore our science and literature? Why do we ignore our science and literature? Why is it that we ignore our science and literature? I don't know. It's just the way the human brain works. So if you maintain muscle, it maintains metabolism. It makes you feel better. You get better strength and endurance to exercise. Isn't that important? Yes. And subsequently, you will reduce whole body fat, subcutaneous fat, trunk fat, and visceral fat. Yes. Isn't that good? Yes. But you don't want to do that. No. Why? Because they don't qualify for it. They don't qualify for this? No. They didn't have a level less than 300, so they don't qualify. So you just let them stay fat and flabby and fatigued? Yes. And stay on all their medications that they're on? Yes. Cool. The medicines that they hate taking that make them feel lousy? Yes. That they don't like taking? Correct. And we could sort of fix that? Yes. But you don't want to fix it? No. Sorry for my sarcasm, but that's the way that it works. So I'm trying to give you tit for tat. I'm trying to give you real world experiences to what you will encounter. Outcomes appeared enhanced with growth hormone supplementation. I don't recommend that because it's so very expensive, but it's an important hormone. It's an anabolic, metabolic hormone, just like testosterone is. Testosterone is much cheaper. Growth hormone is much more expensive. It's supply and demand. But nevertheless, I'm just showing you what the literature shows as far as what does it do to visceral fat? It melts it away. Moving on. Studies show that long-term growth hormone administration is just another hormone that you lose as you get older. Probably reduces morbidity and mortality from cardiovascular disease. Why would you want to do that? Sorry for the sarcasm. Well, if all the studies, study after study after study after study shows this, then why would we not want to use it? Well, you don't use it because it's so ridiculously expensive. But you can understand because the AMA said don't use it for anti-aging. Yes, but what about the effects on muscle mass, fat metabolism, glucose, dyslipidemia, plaque? How many drugs have been shown to reverse plaque? Well, there's a couple studies showing that statins, but they had to use endovascular imaging because they couldn't see it on extracorporeal imaging with ultrasounds because it just wasn't strong enough to measure any difference. So they had to go endovascularly in order to be able to show that statins will shrink plaque with very, very high dose usage. But the majority of studies don't show any plaque reversal. I will, as I did in Beyond Hormones, there's a tremendous amount of data that estradiol reverses plaque. Yeah, and testosterone, and T3, and growth hormone, they all reverse plaque. Look at the studies. It's pretty amazing that you can reverse plaque. Do you know any cardiologists that are using it to reverse plaque? No. What does statins do to coronary artery calcium? It increases it. It increases the calcification, and it does not reverse the plaque, and it causes dyslipidemia and diabetes, yes. And I can reverse that with testosterone by reversing visceral fat, cure diabetes, and decrease plaque all at the same time, and make them feel better on top of it, yes. Which ones does everyone get? A statin. Which one does nobody get? Testosterone. Why? If you can answer that, you'll get the Nobel Prize in Medicine. But it's just accepted fact. I'm trying to tell you real world medicine. This is what the literature shows, but yet we don't do it. But typically, what we do all the time is something that doesn't work all that well and can potentially be harmful in some individuals. But yet we still do it because everyone does it. Why? Well, we're taught and trained by our, take to be procrastinating against medical academies and their guidelines, but you have to understand where the guidelines came from medical academies. If you don't understand that, I can't explain this to you. Growth hormone showed improvement in visceral fat, subcutaneous fat, which is why the cosmetic surgeons like it. It improves insulin sensitivity, which is why some endocrinologists like it. It decreases diastolic blood pressure, it decreases cholesterol, and it decreases triglycerides. Wouldn't it be great if we had a drug that did all that? Too bad we don't. Testosterone may be protective against Alzheimer's disease. Recent reports have identified the protective effect of estrogen in the development of Alzheimer's disease and estradiol, and new studies show that testosterone may exert an even stronger preventive effect than does estrogen in women. Yet we have this new monoclonal antibody that was just recently FDA approved, aducanumab, which is going to be around $56,000 a year. And one study showed that it reverses plaque. The other two studies did not show that it reversed plaque. And all three studies showed that there was no improvement in clinical symptoms whatsoever. But it was sort of FDA approved. Many members of the FDA quit, resigned because for political reasons it was approved. But there's really no study that shows that it works clinically. It reverses plaque, but reversal of that plaque did not result in any clinical improvement. The damage was already done to the neuron. Well, when I did my toxicology fellowship, I was taught that the best treatment for a poisoning was to prevent the poisoning in the first place. Really? Yeah, but now they're poisoned. Well, you should have prevented it in the first place. So how do you prevent the Alzheimer's disease in the first place? Hormones. There's a multitude of studies demonstrating the benefits of estrogen in the form of estradiol, but also Premarin in women that prevent Alzheimer's disease. Same in men. Why is it in men that testosterone protects against Alzheimer's disease and reverses it? It's because of the aromatization into estradiol in men. And some of you may have come into this course thinking that you have to block estradiol because you heard it, or you saw it, or you read it somewhere. Be prepared for me to show you the harm of blocking estradiol in men, because testosterone in men is actually a pro-hormone. T4 is a pro-hormone to T3. It's the T3 at the cell level and at the mRNA that turns on the genes. It's not T4. Same thing in men. Testosterone at the cell level does not turn on anything. It's a pro-hormone that converts either into DHT, dihydrotestosterone, or into estradiol. Those are the two main hormones that result in the benefits of testosterone in men. And that's the reason that testosterone protects against Alzheimer's disease. And the reason that you do not want to protect against Alzheimer's disease is well, they don't qualify for it because the level's not less than 300. So if the level's less than 300, then the men get testosterone. If the level's 301, they don't get it because they don't qualify for it based on a man-made guideline that is designed to restrict the use of it, yes. And so all those men with levels of 301 don't qualify for it and can increase the risk of Alzheimer's disease, yes. All because of a man-made number that you use, pulled out of the air to try to restrict it, yes. And you don't want to reverse cardiovascular disease or visceral fat or diabetes with it either, no. Are you starting to understand my sarcasm? Why is it that we do what we do based on all the literature and science that shows when you do this, it works? It's pretty simple, but yet somehow or another we tend not to grasp it. Let's take a break, please. During the break, Dr. Pang will answer questions for you online. And during the break, you can also come up and ask me questions, if you would, please. My bark is much louder than my bite. I don't bite. I bark, but I don't bite.